Therefore, the overall management of atrial fibrillation is going to be based on the patient's stroke risk using this CHA2DS2-VASc scoring system. If the patient has a CHA2DS2-VASc score of 0, that patient is determined to be low risk, and therefore generally they're going to be on no anticoagulation or may simply be put on aspirin. If the patient has a CHA2DS2-VASc score of 1, then that patient has an intermediate risk of developing stroke, and therefore they should be placed on anticoagulation. If the patient has a CHA2DS2-VASc score of 2 or more, then that patient is considered to be high risk and therefore must be placed on anticoagulation. The main concern that we are going to have, however, moving forward once we place a patient on anticoagulation, of course, is going to be bleeding, as the development of, for example, intracranial hemorrhages or GI bleeds is going to be a major concern. Therefore, there is always going to be this balancing act between our patients having a stroke or having a bleed, as if we do not anticoagulate these patients, then their risk of stroke is going to increase. This is because patients with atrial fibrillation have an increased risk of developing thrombi in the left atrial appendage that can ultimately shoot off and go to the brain, thus causing a stroke. However, of course, if we are anticoagulating patient, this is also going to increase their chances of developing a bleed, and therefore this balancing act between stroke and bleeds is always going to be paramount when we are managing our patients with atrial fibrillation. Now, when we say that we are going to place our patients with atrial fibrillation on anticoagulation, we have a couple of options at our disposal. Of course, we have warfarin. This works by inhibiting vitamin K epoxide reductase enzyme complex, also known as VCORC1. And ultimately, our goal on this warfarin is going to keep our patients at an INR that is between 2 and 3. Additionally, we can also utilize our NOACs, also known as non-vitamin K antagonist oral anticoagulants. These are also known as DOACs, or direct oral anticoagulants. Examples of these agents include dabigatran, rivaroxaban, and apixaban. And of note, some studies have shown that these may have a decreased risk of intracranial hemorrhage when compared to warfarin. Additionally, these DOACs benefit from the fact that they do not need a heparin bridge, whereas in the case of warfarin, we will have to start our patient initially on heparin before transitioning them ultimately to warfarin. And therefore, these NOACs or DOACs are being used clinically at an increasing rate. In addition to anticoagulation based on the patient's CHA2DS2-VASc score, we also have two major strategies for the actual control of the patient's rhythm. These include rate control and rhythm control. In rate control, we are essentially trying to slow down the patient's heart rate, whereas in rhythm control, we are actually trying to normalize the patient's abnormal and irregular rhythm. If we are pursuing rate control for a patient with AFib, and that patient has disease that is chronic as well as is hemodynamically stable, then we can utilize beta blockers, calcium channel blockers, or digoxin. However, if we are pursuing rhythm control, once again in our chronic, hemodynamically stable patients, we can use either antiarrhythmic drugs, or we can use procedures such as percutaneous catheter ablation, in which we can ablate the patient's abnormal foci. Although we use rate control and rhythm control in our chronic, hemodynamically stable patients with atrial fibrillation, there are cases where we can also consider cardioversion. These include circumstances in which the patient is hemodynamically unstable and has atrial fibrillation, or if the patient has recurrent symptoms despite therapy, such as palpitations, angina, or symptomatic systolic heart failure, or if the patient has new onset of atrial fibrillation and it has been less than 2 days since this has occurred, then we can consider pursuing cardioversion. In cardioversion, we are essentially shocking the heart back into a regular rhythm, and therefore when we do this, if the patient has built up a clot in their left atrial appendage secondary to their atrial fibrillation, then this cardioversion can ultimately dislodge this clot, leading to a stroke. However, it is important to note that this clot in the left atrial appendage in patients with atrial fibrillation generally takes at least 2 days in order to form. Therefore, if the patient has new onset atrial fibrillation and has only had this abnormal rhythm for less than 2 days, then cardioversion is going to be considered to be safe, as the patient has not yet had time to form this clot in the left atrial appendage and therefore is not at risk of stroke if we cardiovert them. Therefore, if the patient has new onset atrial fibrillation and it has been less than 2 days since the onset of this irregularly irregular rhythm, then we can proceed with cardioversion, as we can ultimately convert the patient back to a regular rhythm without being worried that they have formed this clot in their heart, which would ultimately lead to a stroke if we were to dislodge it. However, if the patient has had atrial fibrillation for more than 2 days, or if it is unclear what the duration of their abnormal rhythm has been, then we need to get a TEE, also known as a transesophageal echocardiogram. In a TEE, we essentially put a probe into the patient's esophagus, as you can see here on the right-hand side of the presentation. This allows us to go posterior to the heart and ultimately take a look at the atria. We can then clearly see into the atria and determine whether there is the presence of a clot in this left atrial appendage. If there is no clot present, then ultimately we can proceed with cardioversion. However, if there is a clot present, then we should not perform cardioversion and should ultimately anticoagulate these patients. As if we were to cardiovert these patients and this clot were to travel to the brain, then that could ultimately lead to a stroke. And therefore, this cutoff of 2 days of having atrial fibrillation is important not only clinically, but also for examination purposes. We have included here a brief summary of what we have discussed here in this module. This is Boards MD.